Welcome to the Self-Carapist Podcast. Join me, Lorain Moorehead, a licensed psychotherapist, clinical supervisor, and EMDR consultant, along with expert guests as we explore the approaches and modalities we've used and developed to support our clients' success. Our conversations and stories are designed to inspire new and seasoned clinicians to stay curious, prioritize self-care, and never stop learning. Today we have Paris Goodyear-Brown, licensed clinical social worker, registered play therapy supervisor, EMDR-approved consultant, and of course, creator of the TraumaPlay model. She's also the clinical director and founder of Nurture House, which is a thoughtfully imagined treatment center in Tennessee that provides fun, developmentally sensitive spaces that make it easier for families to do the deep work of healing. She's an adjunct instructor of psychiatric mental health at Vanderbilt University, and she provides play therapy supervision and consults with school districts, agencies, and mental health organizations. I personally had a very formative experience at a Paris Goodyear-Brown training in 2009 through the Association of Play Therapy, so you can probably hear the excitement throughout the conversation today. We discuss the foundations of trauma play, the primary agent of change in children, the great minds whose research has inspired her, and she details when and how she learned to incorporate child-directed versus more structured play approaches. She provides an overview of Safe Boss, Nurturer, and Storykeeper, three primary roles that are identified in the TraumaPlay model. We also discuss some elements she considers non-negotiable when designing a playroom. I think you'll be inspired and excited by the opportunities she mentions, as well as the hope and warmth with which she approaches the families and children and supervisees she works with. Welcome, Paris Goodyear-Brown.
Glad to be here with you.
So glad to have you here. I'm excited to ask you a little bit more about TraumaPlay and how it came to be.
Yeah. Well, these days, the farther I get into the development of TraumaPlay, the more I think of it as almost a solution to, I think, what has been historically kind of a whiplash effect that beginning clinicians in play therapy can feel, where they may get really steeped in one specific model early on. And there's, when we're young and we're starting out and we're nervous and we want to do it all right and we want to serve well, we may, whatever we're first introduced to, it may become this is how we do this. This is what's best. This is the only way that's good. And I think perhaps I had a little bit of that at the beginning myself. I was steeped in a child-centered play therapy non-directive model, which is really a beautiful way of working, and it is foundational to trauma play. All play therapists need to practice the being with presence, being able to be fully with the child who is in distress, entering their world, hearing their language, that the whole idea that the play is the vocabulary of children. It is their primary language. And it is the way that, I would say behavior is a second way that children communicate as effectively as they can with us. But play allows for there to be glimpses and snapshots into their lived experience in titrated, gentle doses for them. So in our longer trauma play trainings, I'm showing lots and lots of clinical examples of children who come into the playroom with significant trauma, and they are hungry to play through their trauma with the toys, the tools, the metaphors of the playroom. But when I was steeped in that work, that totally non-directive work, I also had some children with subsets of symptoms who did not have those fully resolved in a strictly non-directive approach. And so I began to chase all over the country, trying to figure out other ways of working, then moved into a second position where I was steeped in, and it was insisted that I use TF-CBT, trauma-focused cognitive behavioral therapy. I was working with significant numbers of children with adverse childhood experiences, lots of domestic violence, sexual abuse, physical abuse, those kinds of things. And that's the whiplash effect comes from that. So from this very non-directive, following the child's lead, to this very protocolized way of working. And again, I found that some of the children were helped with that model and others were not. And so it began to expand my questioning around what does it mean to be an integrative play therapist? And how do I decide what is useful in this moment with this child under these conditions? And that's really what TraumaPlay is meant to be, an integrative play therapy approach that is grounded always in the attachment relationship and understanding that, there are these 20 core agents of change in the field of play therapy that people talk about a lot. I think the primary agent of change for many kids with significant trauma is delight. And they were robbed in various ways of the delight that I think are the kind of rights of children, from the time a little one is put in their parents' arms and the little one goes, aga, and the parent goes, agoo, goo, goo. From those first moments of serve and return interaction, kids begin to be delighted in. And so before they even ever have to walk and be corrected in any way, there's thousands and thousands of repetitions of need meeting and thousands of repetitions of, aren't you the most beautiful, amazing child, before we ever have to say stop when they're about to put their finger in the electric socket. So I think when trauma is in the mix really early on, kids' healthy developmental curves get interrupted. And that's really a lot of what we're trying to give them now in TraumaPlay is recapitulating healthy attachment relationships. So as I chased around the globe, learning these different models of play therapy and other ways to do child treatment work, I'm also an approved consultant in EMDR now. And, there's and somatic therapies and the explosion there's been in neurobiological, neuroscientific understandings of trauma. Polyvagal theory is another piece that we've recently just integrated real deeply into TraumaPlay. And so it serves as an umbrella framework of core components of treatment, really best practices for working with traumatized children. But we present it as an umbrella so that it's really sort of seen as, if we do these kinds of things, if we soothe the physiology, if we increase emotional literacy, if we assess for adaptive coping and then augment adaptive coping when needed, if we offer freedom to kids, and we can talk more about that if you like, in how they approach their trauma, if we acknowledge there's uniqueness in how each child might need to approach that, then we provide protection from exacerbation of trauma symptoms. And in the new, I'm writing another book right now called Big Behaviors in All Containers. That's a second volume for big behaviors in small containers. And there will be an activity in that book and a graphic that shows a caregiver and a child sheltering under an umbrella. And that visual is just so important to me because I really think it is the therapist and the child together as a team, or the therapist facilitating the deeper attachment and rewiring of healthy parent-child relationship, putting arms around dyads, really. That is what's protective in this process. And then within that, we're following the child's need all along the way in treatment decisions. So it's not a one-size-fits-all approach. It's also not a protocolized approach. It is meant to be a set of guiding principles and embodied roles for the therapist, with some core components of treatment that we want to make sure we cover in the course of a treatment continuum, but there's no right or wrong way to follow the need of the child. It's really going to depend on our case conceptualization.
Yeah. Really neat to hear. And even as someone who's gone through many of your works, you can see the integration of so much research. If you were in a trivia game about the research in developmental psychology, I would bet on you, because the way that you pull in, as you mentioned, the CBT, the initial focus of your work, the child-centered play therapy, and then you see where you pull in the research and the integration of the PCIT and how you've learned and researched and incorporated. Early on, how did you use research to illuminate your work? Did you set aside time for it? How did you learn to pull it in the way that you do?
I'm just a geek at heart. Like I love learning. And I think what happened is, I went to my very first play therapy. So in graduate school, they don't, at least in our program, I'm a good clinical social worker and went to a very solid clinical social work program, learned about things like the ecological perspective, learned about differential diagnosis, but no one told me what to do with a child who is throwing a chair at me from across the room or trying to pull their pants down in my treatment session or any of those real life scenarios. So as I met with different children and different needs emerged, I just sought after what's going to be most helpful for this child with this clinical presentation and chased, as I said, all around the country. And I really tried to sit under the mentorship of the people who had developed those methods, so spending time listening to Gary Landreth and now Sue Bratton and Dee Ray, and Sue's a good friend of mine now, and to sit with Charlie Schaefer and let him help me understand more deeply what it means to be a prescriptive or integrative play therapist. And I really do, I would encourage listeners to, TraumaPlay is an advanced model in the sense that it is most helpful to the learning and integration process if you can also take a deep dive into each unique way of working first. So it helps if you already really know how to do child-centered play therapy. You feel like you've really developed the skill set of being able to reflect and describe and track and be with the child. We find sometimes that there's a little bit of there's definitely a learning curve and often a paradigm shifting curve for students in the TraumaPlay certification process. Some of them will come in, like I was, highly steeped in non-directive, and their growth curve is to understand when maybe more structure might be needed for a child. And within our TraumaPlay lens, those times are often when a child is entrenched in significant avoidance symptoms related to PTSD, and they're just going to need more support from the therapist. Hey, buddy, we've done some beautiful play and work together, and you're still having those nightmares. So I think we're going to need to look at that scary thing that happened together. We can do hard things when we stick together. Or supporting the parent in doing the hard thing with the child in that way. You can feel when you're doing therapy that is kind of magical and embodied, and you see the connections happening for people. And so PCIT was one of my, as you were talking about PCIT, parent-child interaction therapy, that was one of my original ways of working with the dyad. Theraplay was another way of working with the dyad that I was exposed to pretty early on, and then went to the Theraplay Institute and did some training directly with them and with Daphne Linder, who I esteem greatly too. And sitting in those spaces where you can absorb the learning and then trying to practice it at least for a period of time. Maybe you even just choose 2 or 3 of your clients on your caseload who you really try to practice this way of working as pristinely as you can, so that you get the felt sense of what that rhythm and cadence and what the change mechanisms are within that connected experience. It's sort of how I learned. And then I read a lot and don't have as much time for the reading now. I still try to stay at it, but I'm just a geek, and that's probably why.
That's awesome. You mentioned the dyad and how you integrate PCIT in it. I think that's reflected in the sort of lengthy, what some would consider a lengthy assessment that you do with your children and families.
Yeah.
That there's really an observational piece, and you're looking at a lot of different, the child at play, the child with the parent. Can you say a little more on that?
Yeah. So, and I would say, The PCIT and the assessment method that you get trained in when you learn PCIT is a 5-minute child-directed playtime, followed by a 5-minute parent-directed playtime, followed by an interval of cleanup, parent-directed cleanup. And theoretically, if things have not hit the fan by then, they often do when a parent is trying to get a child to clean up. But those pieces of assessment from that PCIT way of working are blended with some tasks from the Theraplay assessment method, which is the MIM, the Marshak interaction method. And that I adore Theraplay, and I adore the delighting in quality of enhancing challenge and structure and nurture and engagement for parents with their children. And so we have them do things in this assessment. We call it the NADA, the Nurture House Dyadic Assessment, that allow us to get glimpses of when the child's in charge, how does that look? Can mom even allow the child to be in charge for those 5 minutes? Are there lots of questions? Are there lots of praises or criticisms, or what's the communication pattern look like, and where might we be able to support parents to tweak that? But then we're also looking at some of the prompts are things like adult tells the child a story about when the child was a little baby, beginning with the words, when you were a little baby. And then we see these really marvelous insights into what the story keeping in that family has been like. Because the parent doesn't have time in advance to decide on a story. There's sort of what's bubbling up right away is what comes out first. And so it's likely that it's indicative of the kinds and qualities of stories that get told in this family. And if the parent, for example, says, and we've really seen these sort of 3 different piles, groupings of the way the baby story looks. And in fact, I'm so fascinated by it that we've started creating a baby story coding instrument that allows us to, my ultimate hope down the road would be that we could build out even just this one experience for parents as a way to help other kinds of clinicians who work with kids to get just a glimpse of, do we need to refer this on for a little bit more assessment, this family? Do they need a little more help? Some parents come in and they say, oh, I'm supposed to tell you a story about when you were a little baby. I get to tell you a story. Come here. And they'll have them sit on their laps or come closer. The child will also lean in with glowing eyes, like they know it's going to be a good story about them. The child might help finish the story. There's a lot of nurture in the storytelling. So that's probably a child who gets delighted in fairly regularly. They might have a fairly secure attachment with their parent, and their self-concept is probably pretty good. The second way that people come in and kind of play through that moment, we'll have parents who say, when you were a little baby, I don't know. I don't remember. And there's sort of a lack of remembrance. And we sometimes see it with moms who are struggling with postpartum depression. We can see that with, overworked parents who just were so busy, or if other traumas have happened in the mix since then. That may be a child who didn't get as much of that serve and return as we would hope for. I wonder what that child's self-story might be, on an ongoing basis. And then the third pile of presentations that come in are, when you were a little baby, oh, you cried all the time. And I couldn't soothe you, and we'd have to take you for long rides in the car, and I don't think I slept at all. It's remembering the hardest parts of that baby year. And the telling of that kind of story, I have a lot of curiosity about what is that building in that parent-child relationship over time. So we often work to begin helping parents tell delighting in stories as a part of the treatment process when we see that kind of gap in the parenting toolkit. And it is an extended assessment phase in TraumaPlay. We see the parent or parents only in the first session, and we're really pretty strict about that. When I was in community mental health and our third-party payment system was such that we had to have parent-child in together, we certainly worked that out. But I also found that there would be moments where I would be working very hard to join with a grown-up, with the parent of a child. And that parent is exhausted and maybe even disgusted at that moment with their child. And they're saying, oh, he just makes me sick when it's bedtime and I just can't get him to go. If I nod even a little bit to say, I hear you, parent, and the child observes that, the child may experience me as colluding with their badness, right? So it's important to me that we start being able to be, there's these 3 roles in trauma play for the therapist: the safe boss, the nurturer, and the story keeper. We want to start being those for the parents first so that they can absorb those roles and embody them for their children. Then we do these dyadic assessments where the parent and child come in together and the therapist observes and joins with them in those sessions. We find that's really helpful for the child to be depathologized, that they don't feel like they're a bad kid and that's why they're coming. Their family, as a social worker, I'm a good systems person. We believe it's a systems issue. So bringing them in together to start the process decreases the child's anxiety often and helps them see, and the parents see, this is going to be all of us working this out together. And then we have 2 or 3 individual assessment sessions where half that time is non-directive, child-led work. The other half are things that allow us to look at play-based assessment of the child's current emotional literacy, their current coping repertoire, how they perceive the family dynamics. So it's a good often 5 sessions before we sit with the parent again. Well, the parent's in the first session, and 4 in between, and then we sit with just the parents again, no child present. And we lay out our observations and our case conceptualization, what we think is going on here, and we co-create the treatment plan with the caregivers at that point. And when I started that, I believed in it deeply, but I was also terrified that I wouldn't get any clients who would stay. That's a long time to ask people to stay. And actually, it's felt quite the opposite. Parents seem to feel quite held and like we're really working to understand their dynamics and become experts in their family system before we give feedback. And also, assessment is intervention in the way that we're doing it. Because even asking that parent to think about a baby story is asking them to engage in reflective capacity work, right? So it's all very, we find it to be a rich treatment process, but you can still be a trauma play therapist even if you're working in a situation where you can't do that sort of assessment phase. In supervision and consultation, we help you figure out ways to get small doses of seeing all of that, but maybe quicker.
Yeah. I think that's a great point that often the work starts at assessment. Our clients often are inspired to leave and think over something that they heard or reimagine a story that they've told in assessment. And it sounds like with this process, they're already understanding the importance of the parent or family in the process. They're kind of internalizing some of these messages from the first session. So while they might feel like, well, I'm ready to get to the work, if they notice the work has already begun.
Yes. Yes.
You say something right at the beginning of your Parents as Partners book that really stuck out to me. You mention a time when you might have challenged or encouraged a parent, just hug more, play more, talk more, and how you had this really insightful and vulnerable reflection that there are many parents that are coming in to work with us that don't have that vocabulary and they don't have that set of resources available to them because of their own experiences, and how you've translated that into a more elaborate set of skill building with the parents because you were aware of that.
Yeah, it happened. I sort of shake my head sometimes at some of my early work and just the way we sort of talk at parents sometimes. You need to do this, you should do this. And they will always nod back to us and say, I will hug my child more. But if they don't have that lived experience, if they themselves were not hugged regularly, if they themselves did not get a chance to play when they were little, maybe it's an 8-year-old whose one parent died, the other worked all the time. So they began to take care of the family and make the dinners and, sort of be like a little mama to begin with. That child, now parent, when we say you should play with your child more, they really don't have a template for what that means. And so at the end of the Nurture House Dyadic assessment, we have, and I'm not sure, Lorain, if you've seen the newer version of this, but we've really redesigned it as a stair step of increasingly intensive work with parents. So sometimes a parent simply needs a little psychoeducation when they first come in. So, and that relieves the stress in the system tremendously. Let's say it's a parent who has a little one, maybe a 4-year-old, whose other parent died suddenly. And the parent is very distressed because the 4-year-old doesn't seem to that upset. They seem to be just fine and that they're still playing. They're not crying all the time. And if we can say, I imagine they are when they're watching their TV show, they're all in it. They still love the food they love. But are there times during the day that they would normally be able to deal with change or transition and now they're just having a meltdown about it? Yeah, that's exactly what's happening. Well, that's a child's grief reaction. It's perfectly normal. Children grieve differently than adults do. So a little targeted psychoeducation like that, the parent can often go, okay, everything's okay. That's the first stair on the staircase of how we might need to work with caregivers. And from there, we move into different kinds of skill building that parents often need. Sometimes it's skill building for play skills. How do we play? And we might role play and practice that together, the parent and I. It might be co-regulation skills. It might be more discipline structure skills. Many parents are either high in structure and need some help with the nurture part, or they're high in nurture and they need some help in the structure part. And then sometimes moving up the staircase even further are children or are parents who they just get negatively activated with their kids so quickly, and they need a lot of help with their own regulation, mindfulness practice, breath work, things like that. And then if we're working diligently on expanding that parent's capacity to co-regulate their child and they're still getting negatively activated, there's often some attachment-based work for the parent, looking back at their own family of origin, that might be needed to better understand why they get so reactive in the ways they do now. We call that RAW work in TraumaPlay. RAW is the acronym for reflective attachment work. But I love it because as a parent of 3 myself, it has made me raw and vulnerable. It's sometimes like skin being pulled off your body to look at the places where we may be inadvertently hurting our children, causing harm in some way, and then taking adult responsibility, moving into functional adult self. This work is not for the faint of heart, right?
Yeah, there's a real humility in that reflection as a parent. That first step of psychoeducation with the parent, would you say that's one of the main areas that you use top-down processing? I don't know if I noticed a lot of top-down with kids, but it sounded like that specific area was one of the few times that you really find that it puts the parent's nervous system at ease to just have a little bit of knowledge about what's going on in the brain or in the behavior or in the trauma response.
Yeah. Well, I think the the primary tool we use is our embodiment of the safe boss, nurturer, story keeper for the parent. We want to be with the parent in the ways we hope the parent can be with the child. So that's more felt sense, serve and return work. You might see me rubbing a parent's back. You might see me delighting in a parent's new haircut or something cute that they've got on today. I delight in the parents in the same way I want them to delight in their child. And I try also to hold the very big feelings parents can come in with. I just recently had another situation. Everyone is aware. If you're listening to this podcast, you are probably a clinician and you have probably had to report in a mandated reporting setting, and you have probably had parents with big feelings about that. And the way we hold through the big feelings can make all the difference in how that actual clinical work goes later. So that felt sense work is most important to me with parents. But secondarily, there are a lot of paradigm shifts that we're looking for with parents. And to help a paradigm shift occur, we often do need to provide a little different way to look at it. And that's how I see psychoeducation sounds very, sciencey and maybe a little bit rigid, but like, what is the amygdala and what's it doing? And do we see this as a stress response, or do we see it as the child trying to ruin my life? Right? Those kinds of shifts are the ones we're hoping to help parents make.
Yeah, I love one that you say, which part of the brain am I parenting right now? Mm-hmm. I think that one's really cool because it takes any blame away. Mm-hmm. It's just, I'm parenting a different part of the brain right now, and I can do that now that I know which it is.
Right. We are trying to decrease shame. So one of the things we rehearse often in TraumaPlay supervision is this idea that when parents come in with a lot of shoulds, and shoulds generate shame for us, and the shame can get in the way of the shifts we want to see for them. So we're going to use any kind of a tool that's going to help to decrease the shame for parents so that they can actually risk making the kind of growth movements and changes that may help them connect more deeply with their child.
Yeah. Have you seen throughout your career any shifts happen with the child's ability to play now that a lot of children are using electronics more frequently?
Oh, that's a really interesting question. There is a virtual play therapy field that is developing rapidly now, ever since COVID for sure. And then my dear friend Jessica Stone was working with it tremendously even before that. So you can play in some of the same zeitgeist now, the same spaces that kids would play through screens. We don't work that way super frequently at Nurture House. We often use it in a telehealth setting when we're doing that kind of work. But I find when you have the tools available to the child and there aren't the screens present in this moment while you're working in the real world here, children play just as spontaneously, especially young children play just as spontaneously and are really hungry for it. I think, in fact, it might even be a more pronounced effect because there may not be as much of that happening in other environments for them now. So I think it's really important in that way too.
Yeah. As you were building and conceptualizing Nurture House, and for the clinicians listening, were there non-negotiables that you wanted to have there in terms of things to play with?
Well, we could do an hour on that. Yes. There's a sandbox in almost every room of Nurture House, a sand tray or box or circular environment, something that allows them to get kinesthetically involved and grounded in this very soothing material. The sand tray is also such a beautifully projective space for trauma work to occur. And other kinds of work too, maybe reenactments of social experiences and so forth. But a lot of the psyche can be poured into the sand tray. And so if you don't have unlimited space, that would certainly be one item. Expressive arts materials are another important part just because we're wanting to access cross-hemispheric work for children and their parents. The left brain is all about logical, linear, linguistic, kind of story keeping and telling. The right brain is really often where more of our trauma experiences get stored, and iconically in visual images and somatically in our bodies. So you want to have some ways of kids getting in their bodies in the playroom, and also of showing you what they have experienced visually in the sand tray. So those are non-negotiables for me. I also think things like baby dolls, doctor's kits, handcuffs, things like that, jails, containment devices that pull for children experiencing being able to show us, give us glimpses and snapshots of what's happened. We call that the continuum of disclosure. It's one of the ways kids use post-traumatic play to play through their trauma. And so we have to have the tools that are specific to the kinds of traumas they were involved in. And children will often use the baby doll or little miniatures, vulnerable creatures in miniature, as a self-object. And then they may very carefully watch how we nurture that self-object. They may be able to engage in some nurture work with that self-object themselves, building a sand tray for the bunny. Like, what do we think the bunny needs to feel safe and okay in here? And then we begin to play that through in experiential mastery play work. Those are the kind of big ones. I also think things that call for wish fulfillment, especially with highly traumatized kids, when there's been interpersonal violence or the kinds of abuse and neglect that have taken away a child's autonomy and sense of agency. They don't get to decide later what happens to the perpetrator, right? They might disclose, but there's this real sense of injustice that many of my clients have carried. This happened to me, but I don't get to decide. And so we have wands and Harry Potter hats and wishing jars and dandelions on the walls, lots of ways to pull for wish fulfillment, because sometimes children can, in wish fulfillment or imaginal work, get some of that experience that they won't ever get in the real world. It's another powerful use of play in the playroom.
Oh, very neat ideas. I just have a couple final questions I like to ask everyone. Is there a self-care ritual or anything that you or your clients are participating in that you'd recommend?
Well, because I just feel so blessed to have this really big, like there's 10 different treatment rooms at Nurture House. So there's all kinds of tools that therapists can use. And we story keep for each other in the building. So when I see a clinician who is coming out of a trauma session just covered in the trauma, their shoulders are down, they look like they're exhausted or heavy, they've really been holding deeply for a child or parent, I get to know what works for them and then offer that to them. So let's say her name is Betty. I would be, hey, Betty, can you just go take a couple minutes and jump on the jumperoo outside, like discharge that trauma energy before you go into your next session? And for me, my staff knows that what I will do is when I'm feeling over full with the trauma I've been holding for a client, I will go and lay down on the marble floor of our staff room, laid out entirely, and then imagine the trauma as like brown goo being leached from my body into the cool marble floor. And my staff will come around me and they'll touch me and pat me while I'm letting it run out of my body. But that's the primary practice that I will do when I'm feeling overwhelmed. I also love nature and kickboxing and, feeding the birds. Anything like that is really rejuvenating.
Yeah, that's such great modeling as the supervisor. And also you spoke to the restorative part of supervision, where that is really part of our role as supervisors to attune to our supervisees in that way and offer those opportunities.
Mm-hmm. Yeah.
Well, I thank you so much for being here. It was really fruitful to get to the chance to talk to you today.
Yeah, thanks for having me.
If you're interested in learning more about TraumaPlay and the certification process, you can go to www.traumaplay.com and click the certification tab. The www is important in that web address. And there you can also go to the store and see all of the books that we spoke about in this episode. And you can access a link to all of Paris's upcoming trainings. I hope you enjoyed this episode of the Self-Carapist podcast. If you did, please subscribe and feel free to leave a review. You can also follow along at the Self-Carapist on Instagram or head to lorainmoorehead.com/podcast to grab a free copy of your own learning map worksheet to help track all of the tools and strategies you're interested in learning more about. See you next Wednesday.